Welcome to the NWAETC Project Echo. I'm Kent Underwood. I'd like to turn it over to our medical director, Dr. Brian Wood, to introduce our guest.
Well, it's a pleasure to have Dr. Christine Udell-Flores back with us for another presentation. Dr. Udell-Flores is part of our expert panel here and is a psychiatrist here at Harborview, and I will turn it over to her.
Yeah, thank you so much. Yeah, ADHD and HIV. This is, we're going to talk a little bit about the diagnosis of ADHD first, because there's been some changes since DSM-5 came out last May. It's actually easier to diagnose ADHD now. First of all, you have to have either symptoms of inattention or symptoms of hyperactivity, and usually it's both. To diagnose, they need 6 or more symptoms of inattention, 5 or more for adults, and it has to be basically continual for 6 months or more. So these are a list of some of the symptoms of inattention. You can read down on this: difficulty organizing tasks, not listening, sustaining attention in tasks, making careless mistakes, losing things, and easily distracted by extraneous stimuli, for example. So those are the symptoms of inattention. The symptoms of hyperactivity or impulsivity, you have to have 6 or more symptoms of that, and 5 or more symptoms for adults. So that includes fidgeting with hands and feet, leaving the seat when they're supposed to stay seated, running, climbing excessively, difficulty playing quietly, often on the go, talking excessively, blurting out answers, difficulty awaiting turn, and often interrupting, intruding, and things like that. In addition, the symptoms have to have onset before the age of 12, and it used to be the onset had to be before the age of 7. Now it's before the age of 12. The symptoms have to be there for 6 months or longer, and there has to be clear evidence of clinically significant impairment in 2 or more settings. And so social, academic, occupational functioning. And you have to rule out other disorders that could cause problems with attention. There are some associated clinical features that we see, like low frustration tolerance, sleep problems, risk-taking behavior, overreactivity, and difficulty in delaying gratification. The prevalence, some reports say about 5 to 8% in school-aged children. DSM-5 says 5% in school-aged children. It is more prevalent in males. It's about a 2 to 1 prevalence for males to females. And there's a big percentage of them also have oppositional defiant disorder or conduct disorder. Probably about 25% have conduct disorder. The symptoms are supposed to attenuate during late adolescence and adulthood. However, about half of the children diagnosed with ADHD will experience some persistent symptoms into adulthood, which is 2%, maximum 4% of adults. So according to the American Academy of Child and Adolescent Psychiatry, in order to diagnose ADHD, the psychiatrist should have clinical interviews with the parents as well as the patient, information from teachers about school functioning. They have to review medical, social, family history, and also do a thorough evaluation to rule out other disorders and comorbid conditions. There's several different ADHD scales out there. The adult ADHD self-report scale is probably the most common one. We don't use this to diagnose ADHD. What we use this for is to quantify the behavior and monitor response to treatment. So when someone is diagnosing adult ADHD, you really have to do a thorough psychiatric evaluation. You have to have some sort of documentation that there were childhood symptoms, either school history, school reports, a parent reporting on this adult and their history when they were younger. And you also have to do a thorough medical history, because there are several medical conditions that could mimic ADHD. And we have to worry about a history of substance abuse or other psychiatric problems, because the HD medications can cause psychiatric disorders as well as develop dependence in people. So the differential diagnosis includes addictive disorders, especially stimulant dependence, because people can appear quite speeded up and over talking and interrupting. People can appear like they have poor concentration skills actually when they're high on stimulants. But also major depressive disorder, poor concentration is one of the symptoms of MDD, as well as with bipolar disorder and mania, as well as with anxiety disorder. We also have to rule out antisocial personality disorder, thyroid disorders, fetal alcohol syndrome, could have symptoms of inattention and concentration. There's other learning disorders as well. And then, of course, when it comes to HIV, we have to rule out other CNS pathology, especially HIV-associated dementia, because it is a subcortical dementia. Symptoms of inattention is very common in hand. So when we have patients with HID who say they have ADHD or are interested in ADHD medications, I think it's a wise idea to get not only a psychiatric evaluation, but also some neuropsychological testing and rule out other things with laboratory results or even MRIs in some cases if they have HIV. ADHD is frequently comorbid with substance use disorders. I think we've all had many patients who have, who with a history of methamphetamine use or abuse, who are asking about being on adult ADHD medications. Among individuals with adult ADHD, the prevalence of substance use disorders is as high as 40%. Now, among those in a substance use disorder treatment program, the prevalence of ADHD is about 3 times that of the general population as well. And of course, when the diseases are comorbid, it's associated with earlier onset and worse outcome of the substance use disorder and higher rates of relapse. There's several different medication options, of course, stimulants, which are controlled Category 2 substances, which require monthly prescriptions. And the stimulants include methylphenidate and dexamphetamine, and also lisdexamphetamine. Then there's atomoxetine, which is a norepinephrine-based medication. We'll talk about that in a little bit. Alpha-2 agonists, those are all the DEA or the FDA-approved treatments. The alpha-2 agonists include guanfacine and clonidine. There are other off-label treatments, however, for ADHD. We should consider the non-addictive medications first for treatment of ADHD, and there's several non-stimulant options. The first one being Strattera, atomoxetine, which is a norepinephrine reuptake inhibitor. It increases both norepinephrine and dopamine in the prefrontal cortex. The target dose is 80 milligrams a day. Then there's guanfacine, which is the alpha-2 adrenergic agonist at 1 or 2 milligrams a day. Then there's the off-label bupropion, clonidine, and desipramine. Desipramine actually is a good treatment for ADHD. We don't use it as much, however. There are a lot of adverse effects of psychostimulants: appetite suppression and weight loss, insomnia. Children have growth deceleration. There's also mood lability, irritability, mania, hostility, paranoia, hallucinations, delusions of formication, as well as seizures, headaches, hypertension, skin picking, anxiety, tics, and tremors. So people with Tourette's disorder should probably not be on a psychostimulant because they usually get worse. Bruxism is also common. Now there's also adverse effects of atomoxetine, including appetite suppression and weight loss as well. Hypertension and tachycardia could be present with atomoxetine, headaches, insomnia, irritability, and there have been reports of suicidal ideation in teenagers. I think the rate was listed as 4 out of 1,000, which isn't very much, but it's enough to warrant caution in labeling. So I thought we could talk a little bit about antiretrovirals and ADHD medications because there are several interactions. Methylphenidate or Ritalin and lisdexamfetamine, which is Vyvanse, are not P450 metabolized, so we don't really have to worry about those interactions with the ADHD meds. However, the dexamphetamine, Adderall, and atomoxetine are metabolized by 2D6, so ritonavir and cobicistat would definitely increase their blood levels. Guanfacine is 3A4 metabolism, and the levels of guanfacine will be increased with 3A4 inhibitors also, most notorious of which are ritonavir and cobicistat. When we do treat ADHD in adults with substance use disorders, we try not to, but if they have a real clear history of ADHD as a child, and if they are not using stimulants, and so they're actually in remission in terms of their substance use disorder, we try to use non-stimulant medication first, such as bupropion or atomoxetine. Sometimes it's hard to get atomoxetine authorized through insurance companies. I've had trouble with that. And we do have to worry about diversion. It's particularly a problem with patients with substance use disorders because they can trade the ADHD medication for something of their preference. And diversion is also very common among college students. And so I was looking at some of the diversion literature, and there's a lot out there. Here's a systematic review of the literature looking at over 100,000 subjects. They found that non-prescribed stimulant use over the past year was 5 to 9% in grade school through high school, and up to 5%, all the way up to 35% in college students, depending on the study. So the lifetime rates of diversion were listed as 16 to 29% of students. And that many of those students were asked to give, trade, or sell their medications. Apparently, Caucasians, members of fraternities and sororities, those with lower GPAs, and those who use immediate release Adderall or methylphenidate versus to the extended release preparations, as well as individuals with substance use disorders, are at the highest risk for misusing and diverting. So the reasons to use, misuse, and diversion include to concentrate, improve alertness, get high, or experiment, as well as, of course, to make money. So their conclusions were that you need to really carefully monitor high-risk individuals for the use of non-prescribed stimulants, and we need to educate our patients about the risk of diversion. This is illegal, and this can be dangerous in the hands of other people. For that reason, I oftentimes recommend that people use a controlled substance contract with their patients. I'll talk a little bit about that in a minute. We have a few more minutes here. So here's another study looking at patterns and predictors of diversion and misuse in adult prescribed methylphenidate users. And so they interviewed 66 adults being prescribed methylphenidate. They did structured interviews, and the patients provided details regarding their medication and other substance use histories. Apparently, they used their medication as prescribed on only half of the past month. 44% admitted to diverting it, and 29% admitted to inappropriate use. Of course, they were both those who misused and diverted methylphenidate. Oftentimes had substance use disorders, particularly amphetamine and cocaine use disorders. And so it's relatively common, and we do have to monitor the prescriptions closely in individuals with histories of illicit substance use. People may have past histories of substance use, but substance use disorders are chronic, and there's lots and lots of relapses in a person's life, or there could be. So strategies to reduce diversion. I like to use a substance, a controlled substance contract with my patients. I tell them I'm going to be monitoring their urine for the presence of the drug that I'm prescribing them, as well as looking for the presence of other drugs that may be dangerous if they use them as well as the stimulant that I'm prescribing. And of course, with stimulants, we only can prescribe 1 month at a time. We do need to document amounts and refills, and we have to look for aberrant behaviors. Using the state prescription monitoring program is very helpful. So I would recommend that with anyone that you're prescribing a controlled substance for. And again, a lot of patients don't realize, because this is a prescribed medication, that it can also be very dangerous, particularly with other people. For example, people with tic disorders could get a lot worse. People with cardiac disorders, etc., seizure disorders, So we discuss the illegality of prescription diversion and the consequences of what would happen should they divert or should they be found to be diverting their prescription.